Hello, everyone. Thank you for joining us for this installment of the Root Cause Coalition's How-To webinar series. My name is Monique Brigham, and I'm the Associate Executive Director here at the Root Cause Coalition. Before we get started, I wanted to go over a few logistical items for the webinar. Attendees will be in listen-only mode for the duration of this webinar. The webinar is being recorded and will be available for viewing at the Root Cause Coalition website later this week. That's rootcausecoalition.org. Our panelists will be taking audience questions at the end of their presentation. So if you have a question during the presentation, please type your question into the question pane located at the right side of your screen. We're so excited to have our esteemed panelists join us to share their expertise on how to put your CHNA into action. At this time, I would like to pass it off to Kelly Bruno, CEO at National Health Foundation.
Thank you, Monique. We are, again, very excited to be partnering with the Root Cause Coalition to be putting on another webinar in this series, and excited to share with everyone the work that we've been doing in partnership with Keck Medicine USC. To get started, I would love to introduce the three panelists that will be joining me today and sharing their expertise with us. First is Paul Craig. Paul is the Chief Administrative Officer for the USC Keck Medicine. He serves as the CEO's Chief of Staff and is responsible for several health system departments, including patient relations, international medicine, community benefit and government relations, and the Center for Health System Innovation. Also joining us is Deborah Wyrick, and she is the Special Projects Manager for USC Verdugo Hills Hospital, where she coordinates community-based outreach and education initiatives for the hospital, including the facilitation of its community benefits programming and its tri-annual community health needs assessment and implementation planning. And finally, I'd like to introduce Chad Monk. Chad is the Senior Program Manager for Community Engagement here at National Health Foundation, where he leads NHF's community engagement team to advocate for and elevate community voices in solving local issues. So we've got quite a very robust and talented panel with us today. I'd like to go to the next slide. Thank you. That's so neat how you just say next slide, and there it is. And give you an introduction of what we're going to be doing today. I'm going to give you a brief overview of NHF and a little bit of history as to how this partnership came to be. Then we're going to have Keck Medicine of USC talk about investing in the community environmental scans and why that was important to them. Then we'll move on to the community environmental scans and process and highlights. And then finally, we're going to talk to Deborah over at USC Verdugo Hills and talk about how they're using that scan currently and how they plan to use it in the future. National Health Foundation, and then of course we'll have time for questions from the audience. National Health Foundation's mission is to improve the health of under-resourced communities, and we do that by taking action on the social determinants of health. And part of our mission, or embedded in that mission, is our dedication to both community engagement, and by that we mean that we are dedicated to recognizing and understanding that the communities that we serve need to have a voice in whatever implementation or programs or strategies that are created for them. And we also are very dedicated to the fact that whatever strategies or programs that come of that work, that they be upstream in nature, that we're looking at upstream solutions, because we recognize that that is the only way to really address the root causes of the disparities that we're attempting to address. In 2015, National Health Foundation was one of the inaugural recipients of the Robert Wood Johnson's Root Build Health Challenge. And for those of you that may not know, that was an effort several years ago by Robert Wood Johnson to bring together hospitals, health departments, and nonprofits to address health barriers in a specific community, really looking at that from an upstream perspective. And that was really where NHF began this work. And since then, over the last several years, we have seen a tremendous increase in hospitals and health plans, healthcare systems, particularly across the country, also placing a strong emphasis on wanting to address the social determinants of health and see that as a strategy for improving the health of their service populations and of their communities. But research has also shown us that while there's much interest here and there is much chatter about it, hospitals and health plans are still kind of struggling a bit on exactly how to do just that. So the desire is there, but the how is somehow still missing. So we all know that hospitals do have their required community health needs assessments, or CHNAs, nonprofit hospitals, that they're required to do on a regular basis. And while those CHNAs really lay out the why there is a problem and what that problem is, it lacks a little bit in the now what are we going to do about it. And that is where National Health Foundation's assessment comes into place. It is a methodical, in-depth approach that goes beyond the CHNA to really address the community level needs. So National Health Foundation was commissioned by Keck Medicine of USC to tackle this exact problem for 2 of its hospitals through this unique community engagement effort. NHF produced community environmental scans for each of these hospitals to be used in tandem with their CHNA to develop or support those efforts in addressing the social determinants of health. So with active participation from the residents in each of those communities, these scans were aimed at fully defining the social determinants of health that act as barriers in the communities and act as a barrier for them to achieve their highest level of health. So we are very excited to share with you a little bit about what that process was and how we went through that and how these plans are going to be used at the hospital level. But first, I'd like to turn it over to Paul so he can talk to us a little bit about why the hospital was interested in engaging in this in the first place. And Paul, I'm going to turn it over to you.
Kelly, thank you very much. And I'm also appreciative of the fact, being from USC, given in this current news cycle, that everyone is on listen only. I don't want to hear anything about scandal at the University of Southern California, which I might add has nothing to do with the health system. I want to just say a couple words about Keck Medicine. And I'm going to, Keck Medicine is the umbrella organization. We're an academic health system that owns and operates a community hospital up in the Glendale area, La Cañada, that Deb will talk about in a little bit. The Verdugo Hills communities are very different than where what we refer to as our health sciences campus is in East LA. Many of you might be familiar with USC's presence in East LA. I just want to say a couple words about it, and where Keck Medicine, which is the private academic medical center that's intertwined with but separate from LA County, which is the very large, big public hospital that's just a couple blocks away from us. We're private, university-owned, not-for-profit. This year, we happen to be at the tail end of our triennial CHNA cycle. Our CHNA is due for both hospitals in June of this year. But as a private hospital, I think our single feature about Keck Medicine that makes it maybe a little bit unique. I mean, mostly our challenges with community health needs assessments, with delivering community benefit, community engagement strategies are probably very common to all the listeners to this webinar. I think what might be a little bit unique and present just a slightly different set of challenges, which was part of the rationale for us approaching NHF to begin with, is that we are principally a regional referral hospital that is less connected to our local communities than I would say probably most community not-for-profit hospitals are. We receive a lot of patients transferred by helicopter from places both internationally and across the region, but not too many from our local communities. And yet we also have a very broadly diverse group of communities surrounding us, largely Latino on the east side of LA, but Latino and many Asian communities, Korean, Mandarin-speaking Chinese, Vietnamese, very, very diverse populations surrounding us, and yet we haven't been so connected with them. We're a regional referral center, but we don't have an emergency department, and we don't have an obstetrics department, so we have a very high case mix index, a lot of complex patients. But we, over the years, like every hospital, like everyone listening, we've produced our community health needs assessments, and we have delivered some level of community engagement, community benefit services. I would say over the last couple of years, there's been a little bit of a rising tide of community organizations surrounding us saying, USC, Keck Medicine, you're not doing enough. You're not engaged enough with the surrounding communities. And that has to do with multiple factors. But I think one of the main things is the health sciences campus in East LA is expanding. We have built a few more buildings. We are probably going to be building a flagship new hospital in the next several years. We have definitely expanded our clinics, and so our presence is getting larger and much more active. In the campus, if you're to come visit it, people who see the health sciences campus in East LA will tell you that it looks a whole lot different than it did a few years ago. Our volume has tripled in the last 6 years, but our engagement with the community hasn't kept pace, and we felt a pretty acute need to really make sure that we got under the surface. We also have a new dean of our School of Medicine who has made social justice a pillar of the School of Medicine, and I don't think most folks would necessarily associate the Keck School of Medicine with having a pillar of social justice being a primary driver. So with a number of changes, with the expansion happening, we realized we needed to take a really more dynamic look. Our community health needs assessment process is, I think, pretty routine and very well done. But what the environmental scans have done for us, and we are really mid-process. I mean, we're fairly early. We received the final Verdugo Hills report a few months ago. We're on the cusp of receiving the final Keck Medicine report. But I'll tell you one thing, and I come from the old performance improvement background of it all boils down to structure, process, and outcomes. And I think that the environmental scans as an amplifier of the community health needs assessment really puts things in perspective, makes the routine. We all know that community health needs assessments have a lot of data. They have a lot of community input in terms of interviews and groups of folks that have been surveyed. But putting that data together in a way that's meaningful, that you can get some traction, is sometimes a challenge. And I think what the environmental scans are doing for us is enabling what can sometimes devolve to a relatively routine process, making it more vivid, enabling us to, it's both a structure for us to be able to communicate with, both listening and speaking with our community organizations, and also with our key stakeholders at the health system leadership and at the university leadership, to be able to, it's afforded a structure that's, I think, more vivid and more three-dimensional than our CHNAs have been in the past. And I think it's and I'll just close with this point, and we can talk more later. It's just become a tool that's enabled us to kind of cut through many of the layers of competing interests, and I would say of organizational distraction, because everybody's got a lot more on their plate than it is humanly possible to be done. Probably everyone on the phone is in that position. This is a tool. The way it's designed, it enables you to take options of what you're going to do with the data. I think there'll be discussion later about kind of a tiering, a layering of, okay, here's the issue, here's the social determinant of health area, here's what we found, here are the strengths of the organizations in your area, and here are, if you want to invest, here are sort of, I don't want to say high cost options, but here are more, if you want to address the issue, but you've got to focus on other areas, here are different alternatives. So I think it's the ability to take the data, make it more vivid, get some traction, and to be able to tier what the alternatives are in terms of the things that really have helped us, really made a pathway much more visible for us in terms of working with the community groups.
Hey,
I'm done.
Paul, did you have to convince anyone in leadership at the hospital to support this? If so, how did you go about that?
So I mean, I have the luxury of being on the president's cabinet, so I didn't have to push too hard. But yes, we had to convince the community outreach leadership team and the president's cabinet. I think there was a little bit of organizational readiness, and by that I don't mean organizational readiness to make. We're like every healthcare organization trying to be very cost effective in terms of every area. So it's not like people were saying, okay, Paul, go spend a whole lot more money on community benefit, community engagement. People recognized that the time is right, that we needed to do something more. And I think that the structure of the environmental scans was very appealing to senior leadership. And also to the university civic engagement group. So yes, we had to push. Yes, we had groups that we had to convince. But it was actually because of the way you formatted the offering. It was, I don't want to say an easy sell, but it wasn't hard to convince people that it was the right thing to do.
Thank you. That's good information to have. Thank you, Paul. That was sets us up very well for Chad to talk. Chad, we're going to pass it off to you so you can discuss with us what the actual community engagement and scanning process, what it was all about.
Awesome. Thank you, and good morning and good afternoon, everyone. Paul, thank you for that setup. I'm glad to hear that. I know we talk all the time, but it's always really good to get your perspective on this. So for the actual conducting of the community environmental scan process, there are 4 distinct components, and it started with a secondary data and literature review. So this is really was for myself and our team, our community engagement team, to get a rough sketch of the communities that we would be collecting data from. And it was really public data sets and literature on the target area. So this is similar to health outcome data that is often provided by departments of health services or public health, but with a focus on the social determinants of health. So some examples of the data sets we looked at were the California Healthy Places Index, the Los Angeles County Department of Public Health SPA data and their key indicators of health report, U.S. Census data, and others. But we also really relied on GIS and mapping tools, which allow us to focus in on census tracts or zip codes and get very hyper-local so we could target specific areas. And data points we collected or we looked at while doing secondary data review were things, again, around the social determinants of health, like income level, education level, percent of the population that were renters, percent of the renters that had a high rent burden, food access and SNAP usage, things that gave us insight to possible issues we would come across in the community. During this time, we also looked at other service providers in the area for 2 reasons, really, because it gave us more of a sense of what was happening. So, for example, if a community had 12 food banks, their food access is probably going to be an issue we hear from the community residents, but also it helps later on for other components of the scan where we make recommendations and identify partners and things like that. So the second component, which is really the meat of the scan, is the community engagement or the primary data collection. This is where it's the most labor intensive, but to have a really good sense of what the community is facing and those barriers to health, it makes sense that this is where you're going to spend the most of your time. So so we have 4 components. The community engagement process was broken up even further into 3 different stages. And the first one started with community canvassing. And this was really a self-survey at large community events. It's based on the DOT survey technique, and we attended large events like health fairs, farmers markets, and festivals, where we just set up a booth. And then at our booths, we hung large poster boards with questions printed on them, asking general questions about barriers to health. And we used this approach because, and people were able to come by, write on a sticky note, and put them up on the boards. And we used this approach because it allowed us to get a large volume of answers within a relatively short period of time. It was transparent to the community. A lot of times surveys feel too private or they might take too much time. We wanted to be very open. Like, this is what we're asking, this is what we want to know. And third, it was fun and interactive. People they came up to us, they got to talk to us about their community. They could pick different colors. Kids enjoyed doing it. Sometimes we had incentives. If it wasn't a little toy or a swag item, we had a piece of fruit they could take. And then 4, it really gave us an opportunity to meet other providers in the area. So we were in these large events, and usually we had a staff or 2 handling the table and when people coming up to answer questions. And then we would have someone going around talking to the organizer of the event, other community providers that are there providing services, which again will help later on. The second part of community engagement was our focus groups, and that's exactly what it sounds like. We had groups of 10 to 15 community residents at local sites that were identified or contacted either during the first research phase or during canvassing. And the focus groups allowed us to ask similar questions to what we were asking during canvassing, but then it allowed us to ask why and how. So for example, if someone mentioned that stress was a barrier to healthy living, we just didn't leave it at that. We could ask, how is that impacting your health? Or where is that stress coming from? And then they would go on to say things like, my husband and I spend so much money on rent, it gives us stress that we might not be able to afford food at the end of the month. So that really gave us that root cause answer. So housing cost was an issue. Yes, mental health and stress is a problem, but that's more of a health outcome due to rent and high housing costs. Mm-hmm. Okay, so our focus groups were primarily held at parent centers at elementary schools and middle schools, but we always ensured that we had one focus group with a senior group and with a teenage group. We wanted to get a wide variety of participants and community residents involved. The third portion of community engagement were the stakeholder surveys, which I believe, from my evaluation of traditional community health needs assessment, is the biggest bulk of what is actually done for CHNAs. And so our surveys were administered online to community stakeholders like community-based organization directors, executive directors, local government officials, school principals, or anyone who really understands community issues, but might see them at a different level, like a funding level. So the survey was developed towards the end of the focus groups, and were really tailored to understand the severity of the issues we were already hearing. So again, it wasn't a brand new survey with just a bunch of issues listed out, but it was tailored to the canvassing and focus groups. So instead of asking them like general things, we were more specific. Like if we heard about violence and gangs happening in the community from focus groups, we asked the stakeholders how much did they agree or disagree that violence is impacting health. And with the Likert scale survey, they were able to indicate from strongly agree to strongly disagree, and then they were given an option to explain their answer. Okay, so the third component was data analysis and comparison. And at this point, after doing community engagement, we had pages and pages of data, and all of it was qualitative data. And so each phase underwent content analysis, which really is just that we took what everyone said and coded it and put it into themes or topics, and then we grouped it together. So every time someone mentioned lack of health insurance as an issue impacting their health, we pulled that quote or we pulled that answer and put it with all the other answers in quotes that had to do with healthcare access. Oh, and I forgot to mention that the focus groups, every single one was transcribed from a recording and then underwent content analysis twice by 2 different staff members just for insurance and validity reasons. So once everything was separated into codes, we were able to identify which codes, or at this point they were actual themes and identified issues, were the most common in the community. We identified the top 5 community health concerns and then went back to the beginning and compared that to the secondary data. And we did this so we could actually understand the issue even more, and if it's an actual issue or a perceived issue. And we weren't trying to discredit or ignore community concerns, but we did this to allow us to see how to deal with the concern. So again, for example, in the Keck community scan, we have heard a lot about healthy food access. And when compared to the secondary data, it's very, very clear that food access is a huge issue in that community. We saw that almost all of the residents in their target area live more than half a mile away from a food market. And for the entire area, which serves tens of thousands of people, there's only 3 full-service grocery stores. And plus, we heard other things about transportation issues, not stopping by grocery stores and things like that. So it's clear that the recommendation we would give to the hospital is going to be about increasing access to healthy food. But another example from Verdugo Hills was a lack of services for youth. But when we looked back at the data, it looked like there were a sufficient amount of services. And so the recommendation there, or what we saw was it's not really a lack of services, but maybe a lack of communication or a lack of marketing those programs. Which leads me into our 4th component, which is the recommendation. So after all the data was sorted through and identified and compared to secondary data, we put together these recommendations that could help address the social needs and or the social determinants of these specific communities. And like Paul was saying, these recommendations range in cost and feasibility. Some were lower cost, easier to do with less staff, and some were more upstream, possibly the most upstream that you could get, and would require some program development. Again, one example from the Verdugo Hills report was our recommendations for their drug use issue. So the community around Verdugo Hills actually identified drug use as their #1 top issue impacting their health. But when compared to secondary data, it didn't necessarily show that it was a bigger issue than anywhere else in LA County. It was an issue, but not more so. So then our recommendations aligned with that. The recommendations given ranged from promoting healthy behaviors and resources through hospital print materials to increasing activities in the community that are proven to reduce drug use or drug use initiation. And then the most upstream would be like starting their own social norms campaign. So additionally, other service providers were in the area were identified that would help Verdugo Hills and Keck to find partners or organizations they could partner with to initiate a program or to fund more programming, and who was familiar with the issues in the community that is identified. So that is our overall process, and then of course it all gets written up into a report and sent over to Paul and Deborah. But yeah, that's about it.
So, Chad, I have a couple of quick questions. The first one is, does NHF, does National Health Foundation, did we already have ongoing work in each of these communities before the scans were started? And if not, how did you come to get the lay of the land in order to do this?
Yeah, we do not. In both of those communities, we have not had any direct services, which I think is actually, after we've done the whole process, was beneficial. But to get a lay of the land, it really was that first step, the secondary data and literature review, which helped us understand some of the issues we were seeing. But then really it was the point of the stages of community engagement was starting with community canvassing and not just jumping right into stakeholder surveys or focus groups was very helpful because it opened us up in large ways, like at a giant health fair. For example, at Keck, we attended their Christmas parade. And that was a huge event. There were thousands of people there, and we had a booth, but it allowed us to like just walk in where a lot of people were, like announce what we were doing, but in a fun way. And so I think it's those two specific tactics, the pre-research and starting with community canvassing, not necessarily focus groups or surveys.
That's great. Thank you. I appreciate that.
Yeah.
I'm going to turn now to Deborah and let her discuss how Verdugo Hills Hospital is using the results of the community scan. Using these results of what Chad just discussed to influence their community engagement.
Yeah, thank you. So I just want to start off with a little bit of history about our hospital, just because I think it's helpful to inform everyone on this webinar about why engaging in this environmental scan was so important to this hospital in particular, and probably many similar hospitals are in the same boat. So in 2013, this was an independent community hospital, a standalone hospital that was not a part of a health system, and was acquired, although that's not quite the right terminology for it, by the Keck Medicine of USC's acquisition of our community hospital in 2013, brought with it basically oversight from the California Attorney General's office, because it's one nonprofit sort of taking over another. One of the conditions of that acquisition was that a certain amount of money would be spent on community benefit and would be spent each and every year for the next 5 years or the first 5 years of acquisition, to ensure that this hospital was going to remain a resource for the community, that Keck Medicine of USC was going to be investing in this as a resource for the community. And so there were regular reporting requirements that were involved. There were many challenges. I was not here at the time. I've only been here about 2.5 years. So sort of I came in halfway through this 5-year process. Paul was here actually as not initially in the beginning, but at some point as our interim CEO. So he could speak to this a little bit better. But I think one of the things that we were challenged with was it was a pretty large number for a small community hospital, and I'm not quite sure how that number was derived, but it was $400,000 approximately each year that needed to be spent on community benefit. And that was defined in certain ways and interpreted in others. And I think because we had so many other challenges, in a turnaround situation, that people had to focus on the clinical side of things here and making sure our electronic medical record system became updated, and the infrastructure issues that had not been addressed for many years at this, sort of aging community hospital. Focus wasn't really on the community benefit obligation. And so I think in order to meet that obligation, what we did was we sponsored things. We sponsored things that were sort of in the realm of health and wellness and well-being, but they were cash infusions of other organizations that were doing that work, which is absolutely fine. There's nothing wrong with that, but it was a quick way for us to meet those obligations. But I think as time went on, and there was no position at the hospital at the time, because there was a lot of downsizing occurring, trying to tighten belts. There was no community benefit office. There was no community benefit staff. So that was sort of and then our new administration kind of got used to that. That's how we did community benefit here, was we sponsored things. So again, nothing wrong with that, but not really looking at, downstream issues, root cause issues, how can we as healthcare and leaders and clinicians be helping the community in a more grassroots way. So again, 2.5 years in, we'd sort of gotten into this pattern, and I came on board, and I do special projects, and one of my special projects is part-time position as I look at the community benefit piece and how are we doing that strategically. So we have spent the last 2 years trying to be more strategic and proactive in our community benefit work, ensuring that what we do sponsor is, in fact, organizations that are addressing our community health and needs assessment priorities. For us, those for 2016 were access to care, cancer, diabetes and obesity, and mental health. As a result, we've done more proactive programming. We do community health talks on a regular basis. We host health fairs. We participate in health fairs. We provide wellness classes. We do screenings and immunizations in the communities. We host guest speaker series, et cetera. Another one of our challenges is that, as Chad referenced, the data looks at our service area, and we're in a very interesting part of Los Angeles. We're located in North Glendale, and our most immediately surrounding communities are more affluent. However, our service area extends west and east and serves zip codes where these drivers of health are not being addressed. And so again, that poses another challenge because you've got hospital leadership that's looking at ensuring that we're profitable, that we're, accessing a patient mix and a payer mix that allows us to exist, but then is also able to be available to that different patient mix. So challenging in terms of being all things to all people in our area. However, despite all of that, and despite our good intentions and wanting to do the right thing, we're still doing, and again, we're still operating on our 2016 CHNA. We have not yet implemented our 2019, and that's where National Health Foundation comes in. But everything we're doing is what we think the community wants to hear about, or what we're equipped to be able to do and provide. It reflects our areas of expertise, our service line focus, et cetera. So we don't necessarily, mental health is one of the areas we want to be addressing. However, we serve a very narrow mental health sort of cohort here in our hospital. We run a geropsych, inpatient floor, but we don't inpatient serve youth. So we don't necessarily have any ability to, with our own expertise and our own clinicians, address those mental health issues that youth and teens are experiencing. So how do we do that? So the rationale for us supporting the environmental scan was absolutely we can't. I don't know how we effectively produce a 2019 community health needs assessment and implementation plan without something like what National Health Foundation is providing us. So our rationale was when Paul approached me and said, I'm looking at doing this for the health system as a whole. Would Verdugo Hills be interested? My answer is absolutely, especially if you're paying for it, right, Paul? So,
and a benefactor.
Yes, exactly. You're our benefactor. So, again, the rationale around it is, as Chad referenced, is as us being able to learn from the community itself what they, and the collective they for the community thinks is the greatest barriers to health, and what they want and need, and what already exists or may not be addressing these needs. Right now, I feel like while we've made great strides, and we're in the game, the game is a game of darts, and now at least we're throwing the darts, but I feel like we're throwing them in the dark. And I feel like once we're able to actually take the environmental scan and sort of implement it into our CHNA, or as Paul mentioned, amplify our CHNA, it's going to turn the lights on for our dart game, right? So we still might not have perfect aim, but at least we know where the dartboard is. That's my analogy. I feel that the scan supports the data-driven. Right now, the CHNA in itself is very, very data-driven, and this, again, the environmental scan brings that data to life in a way that it humanizes it for me, and it's my hope that it's going to provide concrete and actionable recommendations for ways in which our hospital can get engaged in community health that reflects community need, not just what we think is needed. And then just to get into the nitty-gritty of the report itself, which is lovely. My favorite part of the report are the recommendation sections, which, Paul alluded to a little bit, and it provides recommendations and best uses of our funds, and how we can make an investment in the community, and provides low investment solutions, high investment solutions. If we have this pool of money, what's the best way to utilize it? We are in this interesting place now where the Attorney General agreement is now complete. We've finished our 5 years, and now we move into the phase of community benefit where we are under the Affordable Care Act requirements. So we need to be investing in community benefit and demonstrating how we're doing that, but there's no dollar amount tied to it. Now, I'm really very thrilled that our hospital leadership has indicated that, there's a commitment to spending whatever it is we were spending up until this point, when we were under the Attorney General requirement. So that's really wonderful. I know we will be using these recommendations and these investment strategies to help us budget. What do we do? It just provides us with an amazing toolbox to inform our community benefit work. Suggestions such as, bringing on staff, perhaps community health educators that go into the community, mental health services that expand beyond the walls of our hospital, people on the ground, boots on the ground. So those are more high investment solutions. Low investment solutions look like, yes, we can still sponsor events and can sponsor events of organizations that are addressing, but now we know the best organizations. We know the ones that are doing the work that the community needs done. A lot of times we're just have been responsive to, the squeaky wheel gets the oil. Well, we've always supported this event, so we're going to always support this going forward. Well, this gives us the ability to hopefully be more discerning in that decision making. So, how is USC Verdugo Health Hospital using the community environmental scan? We're actually not using it yet, but our hope is once our community health needs assessment is complete, we're going to take that document and we're going to take the scan and we're going to ask, the people who were involved in producing those two assessments to sit in a room with our hospital leadership and help us sort of work through what needs to be done, what resources we have to do that, what's makes sense for the community, what also makes sense for us as a hospital, and then out of that conversation, using this tool, develop our community health needs assessment implementation plan. So before, that's always been sort of a CHNA and the implementation plan were sort of done at the same time with sort of made up ideas, I feel like, and maybe I shouldn't say that, but I'm really excited about what our implementation plan is going to look like this June once we complete it. So that's how it's going to be used.
Thank you, Deborah. That was wonderful. It's really, really great perspective. I just have one real quick question before we open it up to everyone else for questions. You've laid out so nicely why this was important for the hospital and what the process was before and what it was now and what you're hoping to obtain from it. But were there any unanticipated benefits of this effort, things that you weren't looking for that actually happened that were also good?
Well, I think, we're just sort of made aware of I guess everything that came out of this report is it's everything I really hoped it would be. Learning about the different organizations that are out there, what they're doing, who to talk to, who the stakeholders are, because again, you only know who you know, and unless you really have a lot of time to network and meet the people in the community and do the boots on the ground work. And as a part-time person who deals with community benefit, I feel like this report is like, and Chad's team is like having another staff member. So I guess that would be the other unintended bonus, is that, we basically had someone who was building bridges and making relationships for us, but now we can hopefully, act upon.
That's great. That's really great. Thank you very much for sharing that.
And that I would only add, on the aspect of the expansion or extension of our community benefit efforts, because there may be hospitals on the phone that have really generous community benefit and community engagement budgets, and that maybe you're overstaffed, and if you are, please call us and let us know where you are. But I think that pretty much everybody in every health system is trying to do more with less, and so that extension aspect, and coupled with the only other point I wanted to make, was that you all make us look smart. Not that we're not smart, but we don't have the time or energy to be able to get to the level of detail. And I don't mean just the data collection. I mean the analysis and throwing out, placing their pragmatic alternatives, tiered strategies, I think is just fabulous and of great benefit to us. So you're adding to our credibility within the organization.
Well, Chad, that's all you. So you should say thank you to that one.
Thank you very much. I appreciate that.
And not to mention the fact that everybody loves Chad. So.
Current company included. Monique, I'm going to throw it back to you and open it up for general questions from the audience.
Wonderful. Thank you guys so much. This was absolutely wonderful, so informative. And I would just encourage any attendees that are that have a question for any of our panelists to type it into the question pane, usually located at the right side of your screen. I guess the first question for all of you is, how long from start to finish was the time frame for the community environmental scan process?
This is Chad. I probably can answer that question the best. From start to finish, and it has taken about 6 months for one scan, and that is from the very beginning of talking about the contract and what we're going to do to submitting a printed report. I do think it could take less time than that. Just in all honesty, this is, and we did this with Build Health LA Challenge, but this was a more elevated report and more elevated research than we've done before. So currently 6 months. In the future, I would say anywhere from 3 to 4. But most of that is spent in community engagement. Focus groups take a lot of time. Just setting up where to host them, getting people there, that takes like 75% of the time. So, yeah.
Thank you so much. Another question, I think, on some of the nitty-gritty of this scan. One of our attendees asked, what types of questions, how did you develop the questions to ensure that they would garner responses and insights that would get you where you all needed to go to help the community in the most impactful way? Was there a special way that you crafted the questions? One of our attendees, I think, is having some struggles with crafting the questions to get the deepest responses.
Yeah, and can I ask a follow-up question? Are you specifically asking in focus groups and community canvassing? Is that what they're looking for? No.
They didn't specify, but I would imagine so, since it was during your presentation.
Yeah, so that's a great question. We based our focus group off of the University of Kansas Community Toolbox, which has a focus group guide. We didn't go word for word off of that, but we did use that as a guide. It's a really good tool. It's evidence-based community engagement tools. If anyone is interested in using that, it's publicly available. But as I said during my section, I think being an outsider was very helpful in this way to ask questions and for people to open up to us. We didn't come in there with an agenda. I mean, National Health Foundation has direct services, but not in the communities that we did these scans. So we didn't come in asking about recuperative care or food access. We just literally tried our best to get a group of people together and then said, tell us about your community. What are you dealing with? And sometimes it took a while. Other times people just opened up and started answering questions. I think if you are a hospital or health system, it might be beneficial to get an outsider to ask those questions, because even if like the most well-intended person from Keck went in there, the community probably would think they're talking about healthcare access issues. We didn't have that issue. We don't have that name that draws people towards certain answers. And we also have really great staff. We have culturally competent staff who speak the language, who understand cultural references. And so I think that was a huge part to it.
You asked. Oh, go ahead, Kelly.
I was just going to say, so what I'm hearing you say, it's not just the questions, it's the method with which they're asked, how they're asked,
yes,
who asks them. It's a complete package. That was really well said.
Yes, thank you.
And just to follow up on that, Chad, one of our attendees, and I think you transitioned this perfectly, asked what languages were the focus groups and the surveys in? Were they in how many languages were they translated into?
Yeah, that's a good question. So for Keck, which is in East LA, it's all of the focus groups were actually done in Spanish. Paul did mention there are other groups there, multiple languages used over there, but and they are there, but it is we focused on 4 communities, and they were 90% Latino and Spanish speaking. So that was in Spanish. Verdugo Hills, as Deborah mentioned, is a very interesting community. It has a wide range of people who speak multiple languages, and fortunately enough, we also have variety on our team, and we were able to do a focus group in the senior group. We had people speaking Tagalog, which is from the Philippines. We had someone speaking Armenian, and we actually had to hire a translator for that one. But yeah, multiple languages across the board.
Thank you. Another question I have, and maybe this could be directed to Paul and Deborah. One of our attendees asked, how did you prioritize, or did you prioritize your investment strategies beyond the dollar commitment, and what other factors did you consider in that in those strategies?
I might need some clarification on really what the question driving at.
I think
both the amount and I think that the environmental scan seemed foundational, and so there was a combination of the fact that we recognized we needed to do a much better job of listening to and actually hearing the local communities, and then the fact that we need to be very cost effective. So we needed to sort of take our limited spend and put it in the right direction. I think that there was a real need, and then part of it was just the timing, the fact that this June we've got to do our community health needs assessment. We wanted to do something more vivid that would grab the attention of the university stakeholders, healthcare leadership, and the community. So that probably doesn't really answer the question, but.
And I'll jump in, but we actually haven't really laid out the investment strategy yet. I feel like this process is a tool to help us do that. I'm pushing for us to use this to help more disenfranchised populations than maybe what we have traditionally done. that's my personal bias, and I'm hoping by having this data and this information and all of these tools, we can make that argument, make that case a strong one when we go to develop our implementation strategy.
Yeah, no, I think that Deb alludes to an important point, and that we both referenced earlier. We're still midstream, in fact, not even quite midstream with the strategy. I mean, these are, first of all, they're actually nice graphics, by the way, guys. They are beautiful reports, well organized, but they're certainly not self-actualizing. So it's up to us now. It is a great tool with multiple facets to it. But if we don't actually take this and walk it all the way through to the various tiers of leadership, then it'll be one more pretty report collecting either real dust or electronic dust on the shelf. So we got to make it happen, and it's made our jobs easier, but we still got to get it done.
Yeah, no, I think both of you definitely answered this attendee's question, and I think it brings up a good point of we do these CHNA processes and we find what the community needs in terms of social determinant intervention, and I guess it's, as you said, Paul, it's imperative for us as systems to be able to address those. And I wonder, are you thinking, and I know you're in the process of developing the implementation plan, but are you thinking about the needs that maybe you can't address? How are you, the secondary needs? I don't want to, triage needs, but if there's only one or two or three that you can address as a system, what happens to those needs 4 through 100? Are you guys thinking about that and connecting with other community-based organizations to help address those?
So I think that, that's one of the needs are myriad, and some are really intractable. For example, in East LA has a huge homeless population, some which are there are a lot of homeless individuals very close to us, but Skid Row is just a few blocks away, and we're not going to be able to, as a health system, solve homelessness tomorrow. But we can engage with the variety of, the whole coalition strategy, I think, is something, and then which community organizations, because we have found that there are some community organizations that we can work with in an honest and an authentic way, and others, I'm not accusing them of being dishonest, but sometimes have some political motivations, sometimes anti-university motivations, that getting a sense of the texture of the organizations, of which organizations we can work with. So incomplete answer to your question, but I think the whole coalition strategy, and then helping us understand some of the community groups that, we know some of the community groups very well, others we don't know about at all, and we've learned about through the environmental scan.
Thank you. And I think that brings us to almost the end of this webinar. I'd like to just open it up for any final thoughts from our panelists. Kelly, anyone?
I just think this is definitely the future of hospitals being able to really operationalize their CHNA. I think it's interesting, the reports, which of course Paul and Deborah don't know, but are very different from each other, yet the same CHNA data is used to create them both, and that's because they really focus on that community that's right around each hospital, which really just brings home the point as to why these types of scans are so important, particularly when you're looking at communities like Los Angeles or other large areas where you literally go 5 miles down the road or 3 miles down the road, and you're really looking at a completely different community with completely different needs and different barriers addressing those, resulting from those needs. So I just applaud USC for our Keck for being a part of this and being really the first that we've worked with to do this. And I just really think that they're visionary, and we just appreciate the opportunity.
Wonderful. Well, just to remind attendees, this webinar was recorded. A PDF copy of the slides and the recording will be up on rootcausecoalition.org, our website, later this week. For those of you that asked questions to the panelists that weren't able to get answered today, I'll be sure to send them on so that the follow-up can happen. Thank you all so much. Just a huge thank you to our panelists for such an informative webinar, and for all of the attendees taking time out of their morning or afternoon, whatever time zone you're in, to listen in. Thank you so much, and we'll see you on the next Root Cause Coalition's How To webinar. Thank you all.
All right.